Welcome to the deep dive. Today we're tackling a really critical, though maybe often overshadowed, aspect of hemodialysis care. We're looking at complications with dialysis access that aren't just about blood clots.
Exactly. We often focus on thrombosis, keeping the access open, but the sources we've reviewed highlight a whole spectrum of other problems. These can really impact patients significantly. It's much broader than just flow.
Okay, right. So let's unpack this. Our research really goes deep into these non-clotting issues. We're talking about things like unexpected bleeding, different kinds of infections.
Yes. And those balloon-like issues, pseudoaneurysms and true aneurysms.
Right, those two. And fluid buildup, seromas, plus some really serious stuff like access-related hand ischemia.
Steele syndrome, yeah. And venous hypertension causing swelling, nerve problems,
Yeah.
even effects on the heart and lungs.
And these aren't just minor things, are they? They can mean losing the access, more hospital visits, a real hit to quality of life.
Definitely. So our goal today is to break these down, look at the causes, what triggers them, and explore the different ways clinicians approach treatment.
Hmm.
Give a comprehensive overview.
Precisely. And just so you know, this isn't just guesswork. This deep dive is grounded in solid medical literature, expert sources, so we're getting a reliable, in-depth look.
Absolutely.
Okay, so where should we start? Maybe with bleeding. It seems fundamental, but it sounds like there are complexities.
Bleeding is definitely common. The sources suggest patients often see prolonged bleeding from the site after dialysis, or they bruise more easily. But surprisingly, the needle actually coming out is pretty rare.
Mm.
What's really interesting, though, is the link to other bleeding issues in ESRD patients, end-stage renal disease, that is. Things like more gastrointestinal bleeding or even spontaneous bleeding in the abdomen.
That's unexpected. You wouldn't immediately connect that to an access in the arm. So why are these patients more prone to bleeding overall?
Well, it's multifactorial. Anemia is the big one. It changes blood flow characteristics. Lower red cells mean higher nitric oxide, which widens vessels and can inhibit platelet function.
Ah,
Then
okay.
there's thrombocytopenia, low platelet count. But often, it's more about platelet dysfunction caused by uremia, the waste buildup. When BUN levels, blood urea nitrogen, get really high, say over 100, the bleeding risk jumps significantly.
And I guess all the repeated procedures at the access site don't help, plus medications.
Absolutely. The procedures themselves, and yes, medications play a huge role. Some antibiotics, like certain beta-lactams at high doses, can impair platelets.
Right?
And then you have antiplatelet drugs, aspirin, clopidogrel, often given to prevent access clotting and for heart protection. A big meta-analysis showed they do help with access failure and cardiovascular events.
That sounds positive.
It is, but here's the catch. Using two antiplatelets together, that nearly triples the bleeding risk. Just one, though, doesn't seem to significantly raise it according to that analysis. That's a crucial distinction for managing meds.
That really is key. One might be okay, two is riskier. What about actual blood thinners, anticoagulants? Many patients see those too, right?
Oral anticoagulation, yeah, it's common. Warfarin was the standard, but now we see more NOACs, the newer agents. The data suggests some, like dabigatran and rivaroxaban, might carry a higher bleeding risk than warfarin.
Hmm.
Apixaban, on the other hand, seems potentially similar or maybe even lower risk than warfarin. Plus, it might offer better protection against clots traveling, like embolism or stroke, and potentially even better survival.
Yeah.
It's complex.
It sounds like a real tightrope walk, managing all these medications. Now, what about bleeding from the access site itself? When does that become a major red flag?
Persistent bleeding, or bleeding that keeps coming back, even if it seems small. That always needs a closer look. Our sources highlighted something quite sobering. A significant number of fatal bleeds from an access were preceded by smaller bleeds, or maybe an infection at the site in the months before.
Wow, that really puts it into perspective. Even minor bleeding needs attention.
Absolutely, don't ignore it.
So what can be done if there's active bleeding or for an emergency?
Okay, for active bleeding, quick fixes include platelet transfusions. They work fast but don't last long, maybe 4 or 5 hours.
Mm.
There's also desmopressin, DDAVP, which helps release clotting factors quickly. But its effect can wear off if used repeatedly.
Right, tachyphylaxis.
Exactly. For a longer effect, cryoprecipitate is an option. It's rich in clotting factors, starts working quickly, and lasts up to 24 hours. If heparin was used, like during dialysis, and the blood is too thin, podamine can reverse it. Recombinant factor VAA is sometimes a last resort, but it does carry a clot risk.
And preparing for planned surgery if someone has bleeding issues?
Careful planning is key.
Yeah.
Minimize platelet dysfunction. Correct anemia, hemoglobin below 10 is common and affects platelets. Erythropoietin helps build red cells, but it takes weeks.
Okay.
Scheduling surgery about 24 hours after dialysis helps platelet function. Aspirin is usually continued, but other antiplatelets are often stopped a week prior. Sometimes conjugated estrogens are used. They can decrease bleeding by boosting certain clotting factors.
And if bleeding happens after surgery?
That needs prompt attention. Often means going back to surgery to find the source. Protamine might be considered if heparin was used. DDAVP could be useful too.
Okay, moving on from bleeding. Infection. Our sources flag this as a huge issue, second leading cause of death and access loss.
It is a major problem, and definitely more common with prosthetic grafts compared to native fistulas. The risk of dying from sepsis is much higher in dialysis patients too. Infections get classified in different ways, early versus late, culture positive or negative, and by location.
What are the classic signs of an infected access? What should you look for?
Locally, you'd look for redness, skin breakdown, maybe pus draining, or even seeing the graft material exposed.
And the usual suspects, what bacteria are typically involved?
Mostly it's single organism, gram-positive bacteria. Staphylococcus aureus is the big one, and worryingly, up to 40% can be MRSA, the resistant strain. Gram-negatives are next, and multiple bacteria are less common.
You mentioned catheters earlier. They seem particularly problematic for infections.
Oh, definitely. Temporary catheters, they're linked to higher mortality, higher infection rates, and they just don't last as long. They're the source for something like 2/3 of all infections and over 80% of bloodstream infections in dialysis patients.
Wow. Those numbers are stark.
They really are. Just having a catheter, the specific dialysis unit, even malnutrition, these are independent risk factors for sepsis with a catheter. Using antibiotic lock solutions has shown mixed results. Temporary catheters carry over 30 times the infection risk compared to a fistula. It really highlights why avoiding them is so crucial.
A huge goal then, avoiding catheter. So looking at the overall picture of access infection.
Most are localized. Comparing types. Temporary catheters have the highest rates by far. The grafts. Fistulas have the lowest risk.
Okay.
Other risk factors. Repeated needle sticks, cannulation technique, hygiene, hospital stays, how long a graft has been in, age, access, location, leg worse than arm, diabetes. Even the buttonhole technique has been linked to higher infection rates in some studies. And gram-negative infections, more common in lower extremity grafts.
So diagnosing isn't just looking, right? What other tools are used?
A good physical exam is paramount, always.
Yeah.
But imaging, like duplex ultrasound, CT, PET scans, nuclear medicine, they can help evaluate, though they don't replace the exam. When infection is suspected, you start broad-spectrum antibiotics right away, then tailor them once you know the bug. Vancomycin and gentamicin are common initial choices.
And treatment approaches. Are they different for fistulas versus grafts?
Yeah, somewhat. Infections in fistulas' autogenous accesses are often linked to cannulation issues or hematomas, usually similar bacteria to grafts, often present as cellulitis or an abscess. Many respond well to 2 to 4 weeks of antibiotics, no surgery needed usually. But if there's a device inside the fistula, like a stent graft, that often needs longer IV antibiotics, maybe even resection.
And grafts. Sounds like they're trickier.
Often more complex, yes. Sometimes only a small part is infected. If it's limited, salvage might be possible, removing just the infected bit, letting the patient keep using the access. But if it fails, the whole graft might need to come out.
Right.
Thigh grafts have that higher risk of gram-negatives and infection spreading. For mid-graft infections, segmental resection can work initially, but recurrence happens. Vacuum-assisted closure can be an alternative after surgical cleaning.
What about infections right at the connection points, the anastomoses?
Those are serious. Usually needs a prompt, complete graft removal to prevent dangerous complications like rupture. If it's a less aggressive bug, maybe subtotal excision is possible, but there's a risk of the infection coming back in the remaining cuff. In critical situations, ligating the brachial artery might be a last resort. Cryopreserved grafts are sometimes used to try and save the site. But early infections generally mean the whole original graft has to go.
And if a graft clots but doesn't seem infected, does it always need removal?
Not necessarily. While a clotted graft could become infected, studies suggest routine removal isn't always needed. The decision depends on signs of inflammation and ruling out other infection sources.
This is incredibly detailed. It shows the complexity. Let's shift gears to pseudoaneurysms and aneurysms. What's the difference and why are they a problem?
Well, some widening is normal, but if it gets too big, say over 18 millimeters or triple the original diameter, it's aneurysmal. Both types cause issues: difficulty cannulating, cosmetic concerns, risk of clots, pain, bleeding, infection. and progressive enlargement can lead to rupture.
Okay, so what's the difference? Pseudo versus true.
A pseudoaneurysm, often in grafts, is usually from repeated needle sticks causing a leak and a contained hematoma, more common with outflow stenosis or older grafts. Less frequent in fistulas.
Hmm.
True aneurysms are actual dilations of the vessel wall itself, often near anastomoses due to stenosis, or in cannulation areas, or near other stenosis or old scar tissue.
How are they treated? Does it vary?
It does. For pseudoaneurysms and grafts, open surgery is common resection and putting in a new piece of graft or a bypass. For fistulas, options include conversion to a graft or aneurysmorrhaphy, basically trimming the excess tissue and sewing it back up.
What about less invasive options? Endovascular?
Yes, endovascular repair with stent grafts is an option. It avoids open surgery, can treat associated stenosis. But there are downsides. Cost, infection risk, skin erosion over the stent, thrombosis risk, potential cannulation difficulty later, and unclear long-term results.
And true aneurysms?
Preferred treatment is often relocating the anastomosis to a healthier vessel segment. Angioplasty might work for smaller dilations linked to stenosis, but it could take time to resolve and might need a temporary catheter. Partial resection and patching is another surgical option. For mid-axis aneurysms, you need a fistulogram to find and treat underlying stenosis. Diffuse degeneration might need partial aneurysmectomy or stapled repair.
Our sources also mention something rarer. Aneurysmal degeneration of the inflow artery.
Yeah, that's rare but serious. Patients might see a pulsating mass or have symptoms from tiny clots traveling down, causing ischemia, nerve issues, pain, swelling, linked to prior ligations, transplant immunosuppression, very high slow. Treatment depends on symptoms, size, patient health, life expectancy. Radial artery ones might just be ligated. Brachial or axillary usually need repair or bypass.
Okay, let's talk about seromas now, these fluid collections. What are they exactly?
A seroma is basically a collection of sterile, clear fluid, like serum, that forms around a graft, usually contained in a fibrous sac. Early ones are pretty common with grafts and often resolve on their own. Chronic ones are rarer, often near the arterial connection.
Why do they happen? Especially with grafts.
The exact cause isn't totally clear. Theories include graft porosity, allowing leakage, failed tissue integration, disrupted lymphatics, maybe even an immune reaction or something inhibiting tissue repair. Certain graft types, like gel-coated ones, seem to have a higher risk,
How do they present and when do they need treatment?
usually within a month of surgery. Ultrasound helps tell them apart from aneurysms or hematomas. They become a problem if they hinder cannulation or make the skin thin and fragile. Draining them with a needle is generally avoided high risk of infection, losing the graft.
So what's the fix?
Surgery is needed if they cause problems. Graft replacement has the highest cure rate. Other options involve excising the graft in capsule, maybe using a different material. Some techniques try to preserve the access using fillers like collagen or fibrin blue, or even percutaneous covered stents with drainage.
All right, let's move to a really serious one. Access-related hand ischemia or Steele syndromes sounds potentially devastating.
It absolutely can be. While most accesses reduce hand flow a bit without major issues, a small percentage cause severe ischemia, coolness, tingling, up to rest pain, tissue loss, even amputation. Prompt evaluation is critical. It's been recognized since 1969.
So what causes this Steele? Why does the access sometimes take too much blood?
It's about flow dynamics. The access is low resistance, so it pulls blood away from the higher resistance hand vessels. Some physiologic Steele is common and asymptomatic. Real ischemia happens when collateral circulation alternative blood pathways isn't enough to compensate. Low blood pressure during dialysis makes it worse.
Are there risk factors? Who's more likely to get it?
Yes. Older age, diabetes, peripheral artery disease, coronary artery disease, brachial-based access is higher in the arm, female gender, large conduits, previous Steele, multiple prior accesses. These all increase risk. High blood sugar can also impair vessel dilation in the hand. Atherosclerosis is a factor too. Brachial accesses generally have higher flow, lower resistance, increasing the risk profile.
Can you predict it beforehand? Any useful tests?
No foolproof test, unfortunately. A low preoperative digital brachial index, DBI, below 1.0 suggests risk, but isn't definitive. A low intraoperative DBI is sensitive, but doesn't perfectly predict symptoms later. Interestingly, a high preoperative DBI over 1 CGR has been linked to increased cardiovascular mortality. A careful preoperative exam is vital check blood pressures, do an Allen test for hand circulation. Avoid an arm with significantly lower BP. Surgically, maybe prefer radial or axillary inflow over distal brachial. Tapered grafts might help in diabetics.
How does it usually present? What signs and symptoms should people watch for?
Varies a lot. Can be hours after surgery, especially with grafts, or weeks, months, even years later. Symptoms range from coolness, tingling, numbness, pain at rest, tissue loss like ulcers or gangrene, to hand weakness.
And physical signs.
Cool, pale, or bluish hand, slow capillary refill, weak or absent pulses, reduced sensation, weak grip, ulcers, gangrene. If compressing the access improves symptoms, that helps confirm it. You have to suspect ischemia until proven otherwise, though immediately post-op, you also think about ischemic monomelic neuropathy.
What diagnostic tests help confirm it and figure out the cause?
Things like finger pressures, pulse oximetry, photoplethysmography, PPG, duplex ultrasound, angiography, sometimes with compression. A DBI below 0.7 is often considered significant. Low finger oxygen saturation too. Serial tests and nerve conduction studies can be useful. Angio and duplex help find the cause, like inflow stenosis in maybe 15–20% of cases, or measuring access flow itself. High flow is common in steel.
And the treatments, you mentioned quite a few procedures earlier.
Treatment really depends on severity. Mild symptoms. Maybe just watch, keep warm, control BP. Claudication or dialysis pain. Close monitoring. Severe symptoms, progressive numbness, pain, tissue loss, motor loss, need swift intervention.
What are the goals?
Relieve the ischemia, and ideally save the access. Strategies are either reducing access flow or boosting distal hand flow. Options include banding, RUDI, PAI, DRIL, arterial angioplasty. Ligation is the last resort.
Can you expand on banding and RDI? How do they work?
Banding creates a stenosis near the arterial connection to increase resistance in the access, pushing more blood to the hand. Can use sutures, ties, cuffs. Tricky to get the amount of narrowing just right. Results vary. Newer techniques like the Miller procedure use balloon sizing and show better results. Percutaneous corset stents can also reduce flow. RUDI revision, using distal inflow, involves tying off the original inflow and rerouting blood from a more distal artery via bypass or translocated vein branch. Preserves native hand flow. Good results reported, but recurrence can happen, possibly due to brachial artery issues. Needs monitoring.
And the other main ones, PAI and DRIL, augmenting flow.
Right. PAI, proximalization of arterial inflow, ligates the original anastomosis and creates a new one more proximally using a short graft. Allows uninterrupted dialysis, uses a larger artery, preserves native artery continuity, good symptom resolution and patency reported, though maybe less effective with severe tissue loss. Dural distal revascularization interval ligation is a key one. You bypass from the artery above the access to an artery below it, then ligate the artery segment between those points. Prevents retrograde flow into the access, provides a new low-resistance path to the hand. Excellent long-term result, often reported, especially using saphenous vein.
Downsides to DUREL.
More invasive, carries surgical risks, wound issues. Patients are often frail. Hand becomes dependent on the bypass. There's also distal radial artery ligation for a specific palmar arch stele with radial cephalic accesses. Need to ensure ulnar artery is good first.
So choosing the right procedure is very individualized.
Absolutely. Symptoms, life expectancy, access function, future options, conduit availability all factor in.
Right.
Rooted drill PI are more major surgeries than banding or ligation. DRIL, often preferred for severe ischemia. Most RHI is high flow, but low normal flow cases happen often due to poor collaterals or atherosclerosis treated differently, maybe drill PI or angioplasty.
Okay, deep breath. Let's tackle venous hypertension next. Affects access function, causes swelling, often linked to central vein problems.
Yes, venous hypertension is a big issue. Often causes debilitating edema, usually due to central venous stenosis or occlusion CVS, found in many failing accesses, though often asymptomatic initially due to collateral veins developing. But CVS threatens the access and future options in that limb. Prevention, early recognition, treatment are key.
What causes CVS? Why do those central veins narrow?
Primarily central venous catheters. Longer duration means higher risk. Subclavian vein access carries the highest risk, much more than jugular. It's thought to be chronic trauma from catheter motion leading to fibrosis and intimal hyperplasia. Also, caution needed if there are cardiac device wires on the same side.
Can it happen without catheters?
Yes, up to 10% of cases. Thought to be due to high flow from the access itself, anatomical narrowings, or valves, especially near the thoracic outlet, triggering smooth muscle growth and stenosis.
How does it present clinically? What are the signs?
Depends on collaterals, obstruction site, peripheral valves. Can be asymptomatic. Physical signs might include old scars, dilated shoulder veins, Declining access function, high venous pressures, prolonged bleeding post-dialysis can indicate CVS. Symptomatic swelling, tenderness, pain can be immediate or delayed. Severe cases get cyanosis, skin changes, ulcers. Some swelling is normal post-op, but persisting beyond 2 weeks needs assessment. Up to 25% might have CVS. Rare, atypical signs like esophageal varices or eye pressure issues have been reported too.
How is it diagnosed? What tests are used?
Duplex ultrasound can help, but might miss proximal lesions. KDOQI guidelines suggest considering a venogram before access creation. If there's a history of subclavian lines, avoid the limb if CVS is found. Duplex is preferred for early post-op edema to avoid damaging the new access. If edema persists past 2 weeks, venography is usually next, maybe with IVUS if needed.
And treatment. What are the options for opening those veins?
It's a bit controversial. Ligation works but sacrifices the access, so salvage is preferred. Endovascular intervention, PTA, angioplasty is usually first line for symptomatic patients. High-pressure balloons are used. But restenosis is very common due to aggressive neointimal hyperplasia. Long-term patency after PTA alone is often poor.
What about stents?
Stents improve immediate success, but long-term patency is still often low, again due to that hyperplasia. Elastic recoil after angioplasty might predict response. Maybe stents help more with high recoil. Stent grafts show more promise, better patency in some studies, especially for graft venous anastomosis stenosis. But caution is needed in central veins not to cover collaterals. Stent grafts also proposed for cephalic arch stenosis and for treating in-stent restenosis.
Any role for drug-coated balloons?
Evidence is still evolving. KDOQI felt it was insufficient for routine use in CVS. But recent meta-analyses suggest DCBAs might improve patency in fistulas versus PTA alone, possibly including for CVS. A small graft trial showed some benefit too. Research is ongoing.
What about open surgery for CVS?
Reserved for cases untreatable endovascularly due to higher morbidity. Can improve symptoms. Good 1-year patency reported. Techniques include direct reconstruction, decompression, bypass using vein or prosthetic grafts to central veins like the right atrium or jugular. Needs careful planning with bilateral venography. Adjunctive banding might be needed for high-flow accesses. The hero graft is a last resort option.
Let's turn to neuropathy now. Nerve problems seem quite common in dialysis patients.
Very common. About 2/3 have peripheral neuropathy at dialysis initiation. Diabetes is a big predictor for developing it after access creation. There are different grades of severity. Generally, we see 3 main types: systemic disease neuropathies, compressive mononeuropathies, and ischemic monomelic neuropathy.
Tell us about the systemic ones first.
Mainly diabetic and uremic polyneuropathy. Diabetic is common since so many dialysis patients have diabetes, affects large fibers, often lower limbs, first numbness, tingling, pain. Uremic polyneuropathy is the most common type overall in dialysis patients, maybe 50–70%. Improves with dialysis, can resolve with transplant, it's axonal damage, worse distally, causes impaired vibration sense, loss of reflexes, touch position sense loss.
And the compressive types, where nerves get squeezed.
Right. Carpal tunnel syndrome, CTS, is much more common, maybe 10 times more in dialysis patients. Prevalence increases with time on dialysis, linked possibly to beta-2 microglobulin amyloid deposits, but maybe also venous hypertension early on. Symptoms are tingling, numbness in the median nerve area, often worse at night or during dialysis, possibly due to ischemia swelling. Early treatment helps. Ulnar nerve compression at the elbow or wrist is another one, causing symptoms on the pinky side of the hand.
And then ischemic monomelic neuropathy, IMN. We touched on this briefly with steel, but it sounds distinct.
It is distinct, though related to blood supply. It's rare, less than 1%, but devastating. Acute nerve ischemia right after access creation. Needs urgent treatment to avoid permanent damage. More common in older diabetics with existing neuropathy paid, usually with brachial accesses, never forearm ones.
How does it present differently from steel?
Acute onset within hours. Severe pain, hand weakness, paralysis, profound sensory loss. But crucially, arterial pulses might feel normal, digital pressure okay. It's often misdiagnosed initially. Need to rule out direct nerve injury or hematoma too, thought to be marginal nerve perfusion compromised by access flow diversion. Nerves are affected before muscle skin. It's like ARHI limited just to the nerves. Nerve conduction studies show changes quickly. Treatment is access ligation or emergent flow augmentation. Even with rapid intervention, recovery might be incomplete.
A very serious, distinct entity. Okay, final category, cardiopulmonary complications. Leading cause of morbidity, mortality, and ESRD, our sources say.
Absolutely. Heart failure, pulmonary hypertension, coronary steel, major issues. CKD patients have accelerated atherosclerosis already. and AV access creation itself has been linked to increased cardiovascular death risk in some studies.
How does the access contribute to heart failure?
A high-flow access increases cardiac workload. In someone with borderline heart function, this can tip them into or worsen congestive heart failure, CHF. Studies show heart chambers enlarge and cardiac output increases soon after fistula creation. A high ratio of access flow to cardiac output is a risk factor, especially with upper arm accesses, though not all studies confirm this link definitively.
What's the treatment if the access is contributing?
Banding to reduce flow, ligation, or maybe flow restriction procedures like RUDI, which has shown promise in resolving CHF symptoms by lowering cardiac output in high-flow cases.
And coronary steal syndrome, related to bypass surgery?
Yes, specifically involving the internal mammary artery, IMA, used in CABG, and access on the same side can steal flow from that bypass graft, causing heart ischemia. Risk factors include subclavian stenosis or just very high access flow. CTA assessment before CABG is wise. If steal occurs with a patent IMA graft, checking the subclavian artery is crucial. Fixing a stenosis there might solve the problem without sacrificing the access.
The sources also mention stents migrating and pulmonary hypertension.
Stent embolization to the heart or lungs is rare but very serious. Can happen due to sizing issues or poor adherence. Can cause valve problems, heart attack, lung damage, shock. Pulmonary hypertension, PH, high lung pressures, is also more common in dialysis patients. Prevalence increases soon after access creation, likely multifactorial. Increased cardiac output, fluid overload, LV failure, high access flow, metabolic factors. Recurrent small emboli from the access are a possible, though unproven, contributor. CKD patients have endothelial dysfunction, making them less tolerant of high cardiac output. Some studies link access flow to pulmonary pressures, reversible with compression. The link between long-term HDA access and pH seems related to increased cardiac output and pulmonary vascular resistance.
Wow, we have covered an immense amount of ground. It really highlights the sheer range and complexity of these non-thrombotic complications.
It truly does. It underscores the need for visual monitoring, early diagnosis, and really individualized treatment plans. That's absolutely key for improving outcomes and keeping that vital access working.
And it sounds like the field is constantly learning more, research is ongoing.
Definitely. As our understanding evolves, treatment approaches will continue to advance, hopefully leading to even better prevention and management strategies.
So for our listeners on hemodialysis, if any of these symptoms or concerns ring true for you, please talk to your healthcare team. Open communication about what you're experiencing is just so incredibly important.
That's excellent advice.
Yeah.
Really vital.
So as we wrap up this deep dive, here's a final thought for you to consider. Given how interconnected all these complications are with the patient's overall health, how can the healthcare community continue to build a more truly holistic approach to access management? One that really looks at the whole person, not just the plumbing, to ensure the best possible outcomes for everyone. Something to think about. Thank you for joining us on the deep dive.